failure and or success of retrieval. I do have a few relative conflicts, actually, that I do need to specifically mention relevant to this. I'll start with the New England Journal of Medicine article published in 1998 that was pivotal and landmark in nature. It's the pre-pick study, which most people are familiar with, one of the few randomized prospective studies looking at the use of IVC filters in 400 patients who all were diagnosed with DVT treated with anticoagulation. They were randomized to receive IVC filter or not. And in fact, the study showed a significant improvement in the amount of pulmonary embolism in those patients who did have a filter placed. There was no effect on mortality early on, and at 2-year analysis, actually, as you can see, there was an increase in the incidence of recurrent DVT in those patients who received IVC filters. So it was a little bit of good news, bad news. It was subsequently published in Circulation 8 years later, 2005, when they looked at follow-up. And in fact, they found that there was a persistent, significant decrease in the risk of pulmonary embolism. Unfortunately, there was also a persistent, statistically significant increase in recurrent DVT in those patients who received filters, and there was, in fact, no effect on overall survival when you compared the two groups. One of the important things to note here is that these filters are all permanent in design. This was back when there was no such thing as retrievable technology that was commercially available. So these filters were permanently implanted. This really raised the question of whether or not a retrievable filter design would be of use, obviously given the risk of decreasing pulmonary embolism but increasing the risk of DVT. You could potentially remove the filter once the risk of PE had subsided and also avoid the risk of subsequent DVT, especially in these patients who had suffered a traumatic event or were younger or had some sort of relatively limited contraindication to anticoagulation for a short period of time. The filter would be taken out and again avoid PE but also avoid subsequent DVT. Not surprisingly, shortly after the development of this technology and became commercially available in the late 90s, early 2000s, the use of retrievable IVC filters in the United States exploded. Went from roughly about 50,000 cases a year, now in excess of 200 to 250,000 filters are implanted annually. The vast majority of these filters are actually retrievable in design, and you can see the growth curve is getting pretty steep. These filters, unfortunately, are not without complications. On your left is an intraoperative image of some filter struts that are perforating and protruding from the inferior vena cava. This is a particular design that's well known for doing this. It has been reported in certain filter designs that up to 85–86% of patients' devices will actually perforate. Luckily, only about 10% of them appear to become symptomatic subsequently. Nevertheless, it's a little bit troubling to see images like this. The image on the right is a completely different IVC filter design, a retrievable device that has literally gone sideways and is now lodged in the infrahepatic IVC just below the right atrium, maybe just a few heartbeats away from this filter becoming stuck in the ventricle, which could potentially be a fatal event. Another example of the more problematic issues related to retrievable filter design. This is the same patient. As you can see, there are a couple of struts broken off. The filter is also now tilted so badly that the retrieval hook is actually extravascular, and on the coronal reconstruction and the CT, you can see that the hook is actually right next to the renal artery, and in fact, during retrieval of this device, the renal artery was damaged, requiring arteriogram and embolization. In the final example I'll show you of a retrievable filter causing undue duress is this example. You can see normal cavogram and subsequent deployment of a filter in excellent position just below the renal veins, as we'd expect. These are comparison images from the IVC filter at the time of placement and 2 months later when the patient came back for the filter to be removed. And unfortunately, there is a broken strut here off to the side, clearly separate from the filter device itself. And on further magnification, you can see it here during DSA cavography. The filter is still in the lumen, although there's clearly perforation of at least a few of the struts. One of the struts is definitely disconnected and appears to lie largely extravascular, and in fact, an attempt was made to try and grab the strut. It couldn't be retrieved. The rest of the filter was retrieved, though, uneventfully. Unfortunately, a couple of weeks later, the patient came back to the hospital complaining of acute chest pain, and in fact, as you can see here, there's a hemopericardium. The strut has in fact perforated the right ventricle. The patient required a thoracotomy to retrieve not only this broken strut, but also deal with the acute hemopericardium and the hole in her right ventricle. So it's a little bit troubling to think about all these retrievable devices being deployed and unfortunately also being retrieved at extraordinarily low rates, as low as 8.5%. And that means actually an attempt to retrieve, not technical success. This was largely due to the fact that these devices were all approved by the US FDA for permanent implantation. So when they were marketed, they were really sold as permanent devices, although they were technically retrievable. So practitioners would put them in and feel reassured that even if they never made an attempt to take it out, this was an FDA-approved device for permanent implantation. If you look at the MOD database, a self-reported database from the FDA, if you look at all of the IVC filter complications out there, nearly 90% are attributed to retrievable designs. That's keeping in mind that permanent devices have been on the market for many, many, many years. It'd be a legacy, you would think, of problems related to these devices, but they're massively outweighed by retrievable technology-related problems. Some of the complications clearly appear to be dwell time dependent, certainly perforation, but then there are other devices that have been reported with a fracture rate estimated at 40% of 5 years of implantation. It's a little bit troubling to think about. I certainly would be concerned if I had a filter in me. I'd think of it as a little bit of a time bomb waiting to go off, as it were. Finally, the FDA came to their senses a little bit, at least, and decided to warn people and say, look, you better take these filters out if you put one in, since they are at risk for complications. So really the objective of our study was to evaluate technical success in adverse events related to retrieving all of these filters and try to identify some of the technical and clinical factors that affected these things. So for a 5-year period, we developed a prospective database. Actually, the retrieval procedure worked closer to 700, although I'm reporting 648 today. The statistics actually do not change for our new numbers. Are closer to 700. We looked at a number of different factors, including technical success, filter dwell time, using some adjunctive techniques, adverse events, filter types, and some patient demographics. I'll review some of these things. When we talk about standard versus adjunctive approaches to removing these things, standard technique is simply use of a vascular sheath combined with a routine, commercially available, FDA-approved endovascular snare device. When these things go smoothly, they take somewhere between 15 and 20 minutes to remove. Unfortunately, not all of them are like that. Some of them get a little bit more complicated, and that's when you start to break out adjunctive techniques that are a little bit more complicated. You might use different shaped sheaths in order to get these things out. You start to loop wires around the filter. You might use different size sheaths. You might use a balloon to try and push the filter off the wall. In this example, you might use stiff endobronchial forceps that are off-label use for this. And finally, off-label use of excimer laser to actually ablate scar so that you are able to retrieve the filter off the wall. Our statistician developed a binary logistic regression analysis model to assess some of the covariates as they relate to technical success and adverse events. Also did a multivariate regression analysis to look at the relationship between dwell time and adjunctive techniques with an alpha set at 0.05. We also did a subgroup analysis, and specifically for demographics, technical success, and use of some of the adjunctive techniques. We split the cohorts into 6-month a 6-month interval, basically saying filters that were in for less than 6 months versus filters that were in for more than 6 months. And that was due to our own clinical experience with this, as well as other people who published in this space, sort of defining 6 months as a critical point. In fact, others have published saying if you can't get the filter out of 6 months, you should just leave it alone. Probably hard to see this, but about a little over half of the filters we deployed are Cook Select filters, although we have experience with virtually every commercially available filter out there, including ALN, Option, Tulip, some of the Cordis products, and other devices that are out there. The average age was 56 years, not surprisingly about half male, and the mean dwell time was a little over 3.5 months for the entire cohort of 648 filters. Overall technical success for retrieval is 97.4%. We had a 3% adverse event rate. There were 3 major complications, 15 minor. There were no fatalities or mortality associated with this. The majors were access-related issues that required hospitalization for a night or 2 for observation. In our multivariate analysis, we really could not find an association between dwell time, technical success, and adverse events. In other words, even if you had a prolonged dwell time, there really was no association with lower technical success or with adverse events. When we looked at adjunctive techniques, there was in fact an association that, oddly enough, if you used adjunctive techniques, you were more likely to be successful. And even more interestingly is when we started to use adjunctive techniques, the adverse event rate was actually less likely to occur. And when we looked at dwell time specifically, we found that there was in fact an association with greater use of adjunctive techniques, which is not surprising. In order to get some of the more embedded filters out that had been in longer, you need to use more aggressive techniques. When we looked at our subgroup analysis, a couple of things shook out that were important. First and foremost, it didn't matter how long the filter had been in. There is no impact or no difference when you compare the technical success. Even 6 months or less than 6 months versus greater than 6 months, the technical success rate was not statistically significantly different. There was a statistically significantly different use in adjunctive techniques, though. For filters that had been greater than 6 months, there was a much higher use of adjunctive techniques. Again, not surprising. Important to note our limitations, namely this is a single center study, and we really did evolve some of these techniques over the time during which the study was performed. And there was also evolution of not only the techniques themselves, but development of expertise of using these techniques. And that was independent of the operators as well. There were about 3 of us who did about 95% of these retrievals. And there was some individuality, although certainly over the study period you kind of develop, you're going to know what you need to use much quicker than certainly early in the experience. And there was pretty broad distribution of dwell time. We had some filters we took out that had been in for 10 years. So conclusions are that dwell time and technical success are not associated. And adverse events are not associated with dwell time either, but use of adjunctive techniques significantly increase with dwell time and are also associated with a decreased risk of adverse events. So what we really conclude from this is that retrievable IVC filters can be taken out pretty much at any time with the same level of technical success, regardless of dwell time and safely. They require more use of adjunctive techniques, but actually this seems to be protective against complications. I think with the growing body of evidence that these devices have certain complications associated with them at fairly significant rate, really there's no reason why retrieval should not be performed in all patients, regardless of how long the filters have been in place. number of different references which you can't read, but I'd be happy to share with anybody. I want to especially acknowledge my co-investigators who are at Northwestern University, where I did the majority of this work, and they continue to work on this area. I would direct you to my Twitter account, and specifically a hashtag #filterout, which is a little bit of a public service hashtag to raise the knowledge about taking out IVC filters. Thank you very much.
We thank Dr. Robert Ryu for his nice speech. And are there any comments or questions from the audience? What were your adjunctive techniques?
Adjunctive techniques involved use of the curved sheath, balloon displacement, loop guide wires, excimer laser use, and stiff endobronchial forceps.
Did the patients have any difference in their medical therapies following the implementation of IVCs? Medically, what did they receive?
Medically, in terms of anticoagulation, it was variable. A lot of it, yes. Some of the filters are deployed, and a lot of the growth in filter deployment's really been in the prophylactic indication, which is really not widely accepted, certainly not great evidence to support the use of it. Nevertheless, they are used in dramatically increasing numbers for prophylactic use. Some of those patients were getting no anticoagulation. Yeah, but others were being fully anticoagulated, so it was very broadly diverse across that group.
Thank you. What was the serious complication? You said there are three.
Yeah, there were three major complications. There was no mortality associated, no deaths related to procedure. The three of them actually were all access site related because we were using fairly large vascular sheaths. We had a couple of patients who developed hematomas, again, that required no operative therapy, but required observation. I think one of them may have gotten a blood transfusion, but they were mostly just observed.
There was no pulmonary embolism after the sequence?
No. We had no pulmonary embolism related to the procedure.
And what is the time limit? You said in dwell time. What do you mean in dwell time exactly? Months or years? Or
so our cohort had a very broad length of implantation. So the dwell time averaged 3.7 months. We had some patients who were in for 2 weeks. We had some filters who were in for 10 years. So it was very broad. In terms of what I think is safe, I think the best period of time is the shortest. So whatever period of time that this patient cannot get anticoagulation is probably the perfect time to take the filter.
That one which was inserted 10 years ago.
Yeah.
The filter will not be incorporated to the wall?
It will, very much so, which is why some of these devices required things like excimer laser, one of the adjunctive techniques I mentioned. When they're very badly scarred in, you actually use laser energy to ablate the scar to free the filter, take it out. We use that in about 30, 35 patients in this cohort.
And there was any case of IVC laceration or perforation?
There was. We actually had one case where we lacerated the IVC and it required balloon tamponade for about 10 minutes. And that was it. There was actually no sequela whatsoever.
Not required surgery. Okay.